Hello friends, I am Dr. Kanika Sharma Sood from Dharamshila Narayana Super Speciality Hospital. Today I want to talk to you about prostate cancer. Why are we worried about prostate cancer? First of all, because it is an emerging problem. Initially it used to be the disease of the West, but nowadays we see a lot of prostate cancer in Indian males, and by and large we see around 28,000 new cases of prostate cancer every year. Also, the incidence happens to be around 9 to 11 per 100,000 of our population. So it is an important issue and we should discuss and should be aware about the risk factors and how we diagnose and how we treat this cancer. So what exactly is prostate, first of all? So prostate is a small gland. We can say it is of the size of a walnut, which is somewhere around the neck of the bladder. There's a urine bag and this prostate gland is at the exit near the outer edge of the bladder, from where the bladder ends and the urine pipe starts, that is the urethra. So whenever this gland enlarges, it tends to cause problems in the urine. So when it increases in size, which can happen even in many non-cancerous conditions, which we call benign prostate hyperplasia or BPH, which can happen in the elderly gentleman. So whenever there is an enlargement, the common symptoms which you can see is, first of all, frequency of urine. You want to void and you want to use the washroom again and again. You feel that the urine is not completely voided. You still have the urge of going again and again. There may be burning in the urine if urine is retaining in the bladder and getting infected. Sometimes if the urine absolutely blocks, there may be a retention and patients come to emergency where a catheter has to be put, and finally we get to know that it's a prostate gland which has enlarged and caused this obstruction. In many cases, there may be blood in the semen or in the urine or sudden erectile dysfunction also. These symptoms overlap much with the benign prostatic hyperplasia, but if the tumor gets enlarged, then there may be spread to the adjacent organs. There may be pressure symptoms in the organs close by, and if it goes to the bones, then patients sometimes present to us with pains in the bone or weakness in any part of the limbs. So it is important that we diagnose in the right time so that patient does not come to us in an end stage or a delayed stage where we cannot cure the cancer. So how do we know that who is at risk for this particular cancer? So by and large, the men above 50 to 60 years of age are affected by this disease. But of late, we are also seeing as young as 45 years of males, especially those who have a genetic predisposition. So there is a risk that if there is a prostate cancer in the men in the family, like father, brothers, uncles, then there may be a risk of prostate cancer. Then these tend to come at an earlier age. But most of the cancers are related to our lifestyle, which predispose to obesity. So anybody who has truncal obesity, the abdomen is more obese than compared to the limbs. There is diabetes, hypertension, there is a tendency of eating fatty food, there is a sedentary lifestyle, more consumption of red meats and less consumption of the fruits, vegetables and fiber in the diet. So these are considered the predisposing factors, and by and large, sometimes there is a patient who may have a BPH and is being followed up for BPH, may in due course of time sometimes have a malignancy, but BPH is not a predisposing or a pre-malignant condition. So we should not confuse these two conditions. So what can be done? So first of all, see, there are some screening tests. So by screening, we mean that we are trying to do some tests in a person who doesn't have any problem. There are no symptoms. So we can screen a person. So screening for prostate cancer is either by a blood test, which we call PSA, which is a simple blood test. If there is a range which is abnormally raised, then we can think that it might be prostate cancer. It is not confirmatory, but it may give a doubt of prostate cancer. Secondly, there is something called digital rectal examination, by which we doctors introduce a finger through the rectum and feel the prostate gland. If it is hard, nodular, enlarged, we can have a rough clue that it can be malignant. But the confirmation is got by a biopsy, and by and large, these are ultrasound guided transrectal biopsies. Multiple cores are taken, and which gives us the confirmation as well as a lot of information which helps us in deciding what would be the treatment. So after a biopsy has been conducted, the next step is to find out the stage of cancer. So we do certain tests, like it may be an MRI of the pelvis and abdomen, and where the PSA values are very high, we may sometimes even consider doing a PSMA PET CT scan, which tells us that this tumor has not gone to the other parts of the body like the bones, liver, lungs, etc. After deriving all the information from this imaging, that is, after you have the stage information, the grade information, then we stratify the patient into certain risk categories. And the entire treatment is based on the risk stratification. The risk stratification makes a patient fall into the category of either very low risk, intermediate risk, high risk, very high risk, regional risk, or metastatic. And depending upon the category of risk, the treatment will be endorsed. So, overview if I can give you, in the low risk, intermediate risk, the options might be either a surgery or a radiation, or if somebody is very old, has a very limited lifespan expected because of comorbidity, or aged more than maybe 90-95 years, then in the low risk or very low risk, sometimes we may not do any active intervention because it is a slow growing tumor. In this situation, there may be something called a watchful waiting or a surveillance. But this decision has to be taken by the treating doctor. It should not be, decided on your own that it hasn't to be treated, because there are a lot of criteria by which we decide who fits into the category of surveillance. Because if we leave the tumor unattended in a wrong patient, then patient will have progression and may, have more complications and end up in having metastatic disease, which is more troublesome, and it is likely to affect the quality of life badly. So beyond intermediate risk, then the options would be addition of certain hormonal therapies, which may be injections, and in usually more than high risk category, it mainly primarily is the radiation therapy with the hormone. Occasionally, in some limited cases, surgery may be offered. If patient has disease spread into multiple organs, then treatment primarily is to give symptom relief, and at the same time also to add some longevity to life. So these include radiation therapies to painful sites in the bones. It would include hormonal therapies and sometimes certain chemotherapies also. Surgery usually is not done in these situations. The only surgery which sometimes may be done is an orchidectomy, that is the removal of testis. This decision again is taken by the doctor, that which patient is the right candidate for this particular type of treatment. So it is important, first of all, that you get yourself screened if you fall into those risk categories by virtue of some genetic or family history. If you're not having a family history, still after age of 50 years, I think it is a good idea to get yourself annually screened. Be it not cancer, but it is important that you get an annual test done which covers all the organs of your body, your lipid profiles, your cardiac evaluation, because as in when we start growing old, our body degenerates and diseases tend to come by 50-60 years of age. So one has to have a routine of annual checkup. Keep it as a birthday gift to yourself, that every year, I'm going to give this particular day for myself and get all my tests done. It will be very relieving when you see that there's nothing in the body. But still, don't ignore symptoms, because in between screenings, if you do have symptoms, do approach the hospitals and get the necessary interventions. Thank you so much.